Yeah, but we reckon there's one person going to be speaking. So.
Julia, you're introducing, so you could be standing up, can't you? There's two speakers here.
Good morning, everyone. Good morning and welcome on the third and last day of our symposium. I hope you're all awake, not too tired after 2 days where your head might be full of all the things we've been discussing already the last 2 days. So just a little announcement. So after this session, we will have the breakout rooms. Same concept as yesterday in the 3 different rooms. Please, for the presentations from the different people presenting there, it's actually the responsibility of the group to present on one of the computers they have from the group in that room, okay? So if they can arrange with one another, that would be great. And now it's my great pleasure to introduce everyone here, and they will introduce themselves, for the session on the tumor microenvironment. Very much looking forward to that, and thanks a lot.
Good morning, everyone, and welcome to the tumor microenvironment session. My name is Julia Foldy. I'm a medical oncologist from the University of Pittsburgh, and I'll be co-chairing this session with Val and Claire. And first, we have Dr. Marleen Kok from the Netherlands Cancer Institute. She's an associate professor and medical oncologist there. She's also the group leader of the Translational Breast Cancer Immunology Lab. Notably, she was the PI of the Gelato study evaluating the efficacy of adding atezolizumab to chemotherapy for patients with metastatic lobular breast cancer, and we look forward to hearing more about your work.
Thank you very much. Good morning, everyone. It's such an honor to be here and to give this keynote lecture. Congratulations to the organization for bringing us all together in this very special place. I think brainstorming here gives something extra, so high expectations for this meeting. And indeed, as said, I will mainly guide you through our expedition, I would say, on starting the first clinical trial in lobular and testing whether immunotherapy could benefit patients with lobular breast cancer. See whether this works. Yeah, so for those of you who know me, this is one of my favorite paintings on, if you think about lobular. The picture has the name Unseen. I think it really applies to lobular because of the difficulty sometimes from imaging. But as an immune cell lover, I also see a link here with, you know, it's cold in this picture. And I think also pathologists will agree that classically lobular is considered a cold tumor type, meaning no immune cells present. But I will show in my talk that this is kind of like an old-fashioned concept, that it's not purely a cold tumor. I would like to bring you back 8 years ago. It was around San Antonio, 2015. Christine de Smet was presenting on immune cells in lobular breast cancer. And here you see that indeed lobular breast cancer has lower TILs than ductal carcinoma. But look at the difference. It's only a tiny difference. And a huge spread amount of immune cells in lobular. And it was interesting because I was sitting next to a pathologist with a respected age, so to say. I don't call him old. But he was like, no, this is impossible. This is lobular, there are no immune cells in there. I think they measured something else. So it was not immediately that this data were like, okay, there are immune cells, because I think we were still in this, you know, concept of, no, this is a cold tumor, there are no T cells there. And also in the same presentation and paper, it's also clear that, you know, it really matters whether you have an ER positive lobular or whether it's a HER2 positive or triple negative. Though rare, the majority of lobular is ER positive, they still exist. And you see, you know, similar as in ductal, that the triple negative and HER2 positive have more immune cells. So not much different than ductal cancer. This is important. You see that the curve, the lowest curve, is the one with the high TIL. And this is different if you look at the curves for triple negative. So classically, TILs have been studied in triple negative a lot. And in triple negative breast cancer, high TILs is a very good thing. Every percentage increase in TILs gives you better survival. This is not the case in lobular. It seemed that those that have high TIL have a slightly, worse prognosis. And at the right you see only the ER positive. So this is not confounded by the triple negative and HER2 positive. Something to think, that is it really that the tumor microenvironment is unfavorable, or is it a proxy for some other unfavorable prognostic feature? Again, 8 years ago, so at that time I was still doing my residency and opening eyes on breast cancer. This paper came out more or less at the same time. It's coming from the TCGA group, published in Cell, and it's like TCGA genomics. That is classically what the papers are about. So they present things that I think now are quite common, that lobular, in contrast to ductal, have more, aberrations in E-cadherin, more mutations in ESR, more aberrations in PI3 kinase and AKT. So that was, not really surprising. But they also present gene expression data. And here you see 3 subtypes, molecular subtypes based on gene expression. Proliferative in black. In red you see the immune-related as well as the reactive-like. And genes that are discriminating, so all in lobular, are genes related to macrophages and T cells. So that's not a surprise. Also in this paper, they show it's not that those with a lot of immune cells have the best prognosis. It's also not clear that it's very poor, but at least this suggests that the tumor microenvironment is not always consisting of purely effector T cells. Again, 2016, a similar paper. I think in science, if things happen together, it means that it might be true if it comes from different direction. Some people feel, especially in my lab, when people are young, they feel like scooped. They published what we already found, and they were first. But I think it is important that the whole body of evidence points into the same direction. This is coming from NKI, together with Cambridge, a consortium rather on lobular. And here again, they present 2 subgroups of lobular, immune-related as well as hormone-related. You also see that the hormone-related have higher levels of estrogen receptor, making sense, but it's not that all the ER low end up in the immune-related part. They're also highly ER-positive, immune-related lobular breast cancers. They did pathway analysis on what kind of immune cells can be found in this immune-related. It's a mixed bag. Effector cells, innate immunity is present, the usual suspect cytokines and chemokines. Also, there's a lot of mechanistic data in this paper. I don't have time to present it to you, but here you see that they also find higher expression in PD-1, PD-L1, CTLA-4, but also they performed, depending, cell lines of different subtypes, that the immune-related subtypes might respond different to chemotherapies. They might benefit more from the chemotherapy that is affecting the DNA damage. Classically, that's cyclophosphamide, carboplatin, cisplatin. So this plot shows you that the lobular cell lines, immune-related, are more sensitive to cisplatin. But we don't use platinum for lobular. So this also is hypothesis generating. I think it was also San Antonio 2015. Imagine that you love immune cells and you see all of a sudden lobular and ER-positive and immune cells. So this is the first data, checkpoint blockade, so Pembro, ER-positive, metastatic disease, the Keynote 28. And basically what it is end stage, I don't like this terminology, but heavily pretreated metastatic ER-positive. And there are lobulars in there, only a few, but at least they were allowed. And usually those trials, they're restricted by patients with measurable disease. And lobular, it's not always a type that is easy to measure if you think about bone and lymph nodes, skin. But at least they're in there, and they present it in table 1, which is important because that's not frequently done. There were, in this PD-L1 positive, metastatic ER positive, there were a few responders, about 20%, which is amazing. I think heavily pretreated ER positive, important. But if you have a close look at the paper, there were 3 long responders, of which 2 were lobular. That was a surprise. So only a few lobulars in there, but at least there were some responders in the lobular. So I think, and even if you read the discussion of that paper, the authors, it's a pharma study, they were fascinated by it, and they encouraged, like, maybe we should do trials for lobular with immunotherapy. So I work at NKI, and we really have this clinic really attached to laboratories. And during my PhD, which was mainly focused on molecular science, so gene expression, MAMA print at that day was very popular. But there was this postdoc in the lab of Jos Jonkers working on lobular breast cancer mouse models, Karin de Visser. And even before 2015, she was studying immune cells. She was the only person at NKI, basically. And everyone was like telling her, what are you doing? Why are you looking at immune cells in lobular? They don't exist. But she kept going. She kept going with the work. And I think that's important, that if you believe in something and you have observation, that you proceed. So more or less at the same time, the lobular mouse model, so it lacks ECAT hearing and it has a P53 aberration. Here you see if you treat that in that mouse model with immunotherapy. So not much is happening to the tumor growth. But then if you treat with cisplatin, the curve in purple, you see that the tumors respond, at least slightly to cisplatin. But then if you combine immunotherapy with cisplatin, you see a survival advantage for the mice, suggesting that, as suggested with the other paper, that combining immunotherapy with certain chemotherapies that are not that obvious for lobular might be a good thing. And it's interesting, they also tested, is this really like immune stimulating? So they depleted the CD8 cells and then they lost their effect. So this suggests that this is really a treatment combination that stimulates the immune cells. So that brought us to the hypothesis. Okay, maybe we should test immunotherapy for lobular, but maybe we need something extra. So maybe certain, DNA damaging together with it. So how could that work? So DNA damaging agents, they damage the DNA, and there's much of data that it can result in, let's say, a viral response. So type 1 interference, STING pathway, classically known for viral response, stimulated by the chemotherapy. Also, it can result in an upregulation of MHC class 2. MHC class 2, it's important for your T cells, because those molecules present antigens to T cells, so you need them in place for a proper immune response. So maybe with checkpoint blockade plus platinum, we can overcome, the cold lobular tumor microenvironment. So that's why we embarked on a gelato trial. So for those of you who don't know Italian, gelato means ice cream. So there's this cold nickname. It's also, we like names that people can easily remember the trial instead of a certain number. We could also have picked a, lobular trial number 1. That would also have been nice. So what this is for metastatic lobular. We started with 2 weeks of carboplatin at a very low dose, not to kill the tumor cells, but to really prime the tumor microenvironment. And then we start treating with immunotherapy until progression. And because of the chemotherapy can result in, immune cell depletion, we stopped it after a few weeks. So inclusion criteria: metastatic, lobular, endocrine refractory. Certain patients were pre-treated already with chemotherapy. ER positive, triple negative, HER2 positive was not allowed because we couldn't give anti-HER2 treatment. We didn't have the criterion for measurable disease, but at least, possibility of taking a biopsy. Maybe for patient perspective, not always fair, because you need to be lucky if there's some lesion easy to biopsy, but this is really for the science that we could say something on the tumor microenvironment in a small trial. The endpoints are very classic: progression-free survival. And the statistics we did is a small trial. And because we didn't know anything on what could happen, we started with a small number of patients, 22. And if we would say, okay, we have a certain number of responders, then we embark on the second stage. And here you see baseline characteristics and also a chart on the patients that we screened but were not able to enter the trial. And basically what you see here, that the patients that entered the screening or even were not entering the screening, those discussions we had most on, is it really lobular? What does the ECAT hair and staining tell us? So there's really a couple of years ago having consensus on this with different pathologists ended up in discussions, and that the study team, you know, had to say, okay, there is a discussion whether it's purely lobular, patient cannot participate. So I think it's important for trials that there's consensus, that for a certain patient that there's not like this whole discussion on whether it's lobular or not. Also, what really struck us was that if you have lobular metastatic endocrine refractory, it was more than a handful of patients that progressed so fast, because lobular is usually considered like indolent. It's not. If it's endocrine refractory, it can progress within 2 weeks. That's, you know, you can say, okay, maybe you're eligible for a trial, but in the screening period, that patients deteriorate. I think that's important to realize if you consider, you know, treating metastatic lobular. And you see in the baseline table that we also included a handful of triple-negative lobular. At that time, immunotherapy was not available in the Netherlands for triple-negative. So especially for those, we got referrals. So we have a kind of an enrichment for that population. So here you see the efficacy results. Of course, it's a small trial in the first 22 patients. We saw that 6 patients benefited. So 4 with a response and 2 with stable disease, which met the preset criteria of success, because we didn't expect much. And in this line of treatment, usually the progression-free survival is 2 months or 3 months. So every response is important. Here you see the duration of the response and how it panned out for ER-positive versus triple-negative. You see that some patients really had a durable response over 1 year. The majority of the responses were triple-negative. So out of 6 responders, 4 were triple-negative, which is, in hindsight, as expected, also for the platinum, because platinum is used in triple-negative. So what this teaches us, that triple-negative lobular, maybe the disease course is dominated by the triple-negative and to a lesser extent to a lobular. We also see very deep responses, and you see in this spaghetti plot. So unfortunately, the lady with the longest response, she recently progressed. So she had a durable response for a couple of years, but it was not sustainable as you would have hoped. Subgroups, again, very small numbers, but again, you see the triple-negative, higher chance of having clinical benefit. Also very classic that those women with liver metastasis less likely to benefit, as observed in many other cancer types. Let's have a look at the baseline characteristics and see whether we can tease out the difference between those 6 responders versus the rest. The numbers are small, and that's really hampering statistics, but it's not a clear difference. The responders had a bit higher expression of PD-L1, but also in the non-responders there was PD-L1 expression. Same for CD8. We assessed a tumor mutational burden, so amount of mutations, mainly in lung cancer that's related to response to immunotherapy, not really in breast cancer. That also didn't pop up in our analysis. You also see the different mutations, PI3 kinase, aberrations in PTEN, for example. There's no clear pattern on which patients benefited from the platinum plus immunotherapy. Because of the biopsies, we could study changes in the tumor microenvironment. And this is simply on H&E on TILS. I think TILS is standardized for primary tumors and not really for metastasis, because you look in the tumor microenvironment in different organ. So some pathologists are really hesitant to really score TILS in those biopsies. But at least the pathologists that were involved and loved lobular provided TIL scores. You see that in some patients, the platinum resulted in a bit more immune infiltrate. But basically, you can also see the data all over the place. It's not a clear pattern that TILs were upregulated with the chemotherapy induction. And same if you did a split by responders versus non-responders. So a few responders really had like a steep increase in TILs. So maybe for those, the induction with the platinum was critical. When we zoomed in on the CD8s, you see a pattern that is becoming more clear. Especially after starting immunotherapy, you see an increase in the CD8s, so the most important effector T cells. Of course, the numbers are small, but it suggests that lobular, you can really, with immunotherapy, create an anti-cancer immune response. Here again, the split by response and non-response. On gene expression, you can also study immune cells. Of course, it's bulk gene expression. At that time, we didn't collect samples for single cell. But what these plots tell you is that not with only the CD8s tend to increase, but it's really the exhausted CD8s. So exhausted sounds a bit negative, but in immunology, if cells are exhausted, it means they have been exposed to antigens. So those are the one, if you can stimulate exhausted T cell, those are the one that can kill off a cancer cell. And you see a slight increase. And the same is for, cells related to immune checkpoints, for example. We also collected, with patient permission, the primary tumor, years before. So I think that's important if you work with pathologists, that you can really make a plan. Can we collect all the materials of patients that have participated in trials? So we could study so-called immune evolution. So is it really the case that maybe the metastasis is cold, but maybe the primary tumor was hot? And you see primary tumor, for some we had a sample for the recurrence, and then at the right you see the biopsy from the trial. And in general you see what you see in other cancer types. You see that the T cells go down. Also what strikes us is that certain types of mast cells massively went down. I think we don't know much on what this happens and what types of mast cells are here, but this suggests that mast cells in lobular could be important for immune control. And the same is for B cells. So memory B cells steeply going down when the disease progressed. I think we don't understand a lot on whether B cells are simply like a bystander, like a helper T function, or whether this tells us something and that we could use for more more targeted immune modulatory treatments. So in summary, what we can conclude from the Gelato trial, at least that we were able to do a trial for lobular breast cancer patients. And I think also thanks to you here, the community, for the awareness of disease, that people really thought the time was there to do a trial specific for lobular. We saw 6 patients benefiting, which, 26% met the criteria that we were pre-specified. But since it was mainly for triple negative, the study team decided not to embark on the second stage because the triple negative lobular already had access to immunotherapy. It was nice, so we published this last year in Nature Cancer, and it got a nice attention by the Nature journals. So Nature Research Briefing. So I consider those pieces like the making of. It's like an interview, not on the data, but what is your experience and what does it tell? And they really highlighted, the first trial for lobular. Also, if you read, they talked about this consortium. And that this consortium, bringing people together, at that time there were 23 centers involved, and also the role of patient advocates. It's in the Nature paper. Also, the expert opinion was, it's not only a negative trial, but this is proof of concept. And this forms the basis for more trials in lobular. And those trials are mentioned in this research briefing as well. Certain lessons that are not, typically in the paper, but that in hindsight, if we reflect on it, on our experience, it was very challenging to get pharma on board. In general, it's challenging to get pharma on board for academic initiatives. That's not news. But, talking to people in pharma and explaining the particular need for lobular, you really depend on a single person in a company that understands the problem. Because in general, pharma is like ER positive, triple negative, HER2 positive. Yeah, the lobulars can go ahead. They don't realize that usually the disease pattern is different, no measurable disease, underrepresented in clinical trials. So I think there's also not only a role for pharma and for us explaining, but maybe the time is ripe that regulatory bodies, in the end, approving drugs, approving trials, FDA and EMA, are going to discuss this. That a trial needs to represent a certain breast cancer population, or that data on the lobular should be presented in the primary analysis, because that's usually not done. And I think you have discussed that already in the last days. As said, lobular is not an indolent disease in a metastatic setting. They can deteriorate very quick. It's important for trial participation, for physicians, but also for patients to know this. And also for, if you want to do the trials for lobular, based on histology and ecatering, consensus, not only in academia, but also at the local pathology level, is important. And creating awareness that lobular histology is important. So I recently took over you know, a clinic from a colleague that went on retirement, wonderful colleague, but not, you know, involved in lobular research as that we are doing here. So, you know, going over those patients' records and explaining to the patient, okay, let's make a summary of your treatment history. I mentioned lobular, and then certain patients were like, what's lobular? Is it a good thing? Is it a good thing? Do I like this? And so I explained it is not per se a good or a bad thing, but it's a separate entity. They didn't, you know, I was the first telling them, while they had a disease course metastatic for 5-6 years. Not blaming that colleague, I think that's a sign that there should be more awareness for treating physicians and also for patients. So what's next? So I said we didn't embark on a Gelato 2 trial because of the reasons I explained to you. So this is not comprehensive, but some ideas on where the immunotherapy for lobular could go. So next year we will see phase 3 data of the Keynote B49. That's the large phase 3 for endocrine refractory metastatic, very classic chemo and then added pembrolizumab. We had the trial open at our institute, so I could, you know, check the protocol. So if you do control find, control F, lobular, nothing in the protocol. Which is strange. It should, in my opinion, be like one of the specified analysis. But at least they were not excluded. Also, in our center at least, we entered a few patients with lobular in the trial. So I think this is important. And I hope that the people from MSD that's sponsoring the trial will present the data. I think there's still a really urgent need to define those lobulars that, you know, can benefit from immunotherapy. I think the Gelato trial was simply too small to really come up with a biomarker. It's more providing hints in which direction, you know, a potential biomarker could go. And I think, so I made a typo where it's wish, it should be which, but maybe it's my wish as well, to understand, you know, which cell types are important. I showed you the mast cells go down, you know, terribly, the B cells go down. So I'm really looking forward to the breakout session after the break to discuss on what immune cells, you know, should get more priority in the lobular research field. Then a bit on early stage lobular and how that field could move. It's again not comprehensive, but I will show you the two phase 3 trial that presented data last year, the Keynote 756 and the Checkmate 7FL. So we have seen PCR data, I will show you, but we are currently waiting for survival data. So this is, you know, landmark trial from MSD, Keynote, and the design is chemotherapy and pembrolizumab is added for a total duration of 1 year. It's high risk, mainly grade 3 ER positive. And you see at the right the PCR data. Yes, by adding immunotherapy for ER positive high risk, you have a higher PCR rate. Of course, you know, we have to see whether that translates into survival. Though this is for high risk, lobulars were not able to participate. I think this is really a problem. Also, another high risk group is the N3. So the nodes close to the sternal bone, nodes, you know, beyond the axilla. Those were excluded. So the patients that are in highest needs are like high stage lobular are not in this trial. I think that's a problem. Then you had from the competitor BMS making nivolumab more or less the same trial with more or less the same inclusion criteria. In their key inclusion criteria, they didn't say doxil. But again, we participated in this trial, and if you look at the very tiny letters in the protocol, lobulars are excluded. I think this should really change. And again, the really high stage are also not in this trial. I think if for pure trial reasons, you note up here and your endpoint is PCR, you don't remove those notes. So technically, yes, you cannot measure the primary endpoint. But I think it's important to be, as in society, also in clinical trial, to be, you know, inclusive here. Again, you see, similar to the pembrolizumab study, you see an increase in PCR for high-risk ER positive. This is important news. We have to wait for follow-up data. But this at least suggests that ER positive is not a cold tumor. So recently we, as more the triple negative community, we got together to discuss, you know, with those pharma trials and they dominate designs, and they dominate, together with regulatory bodies, you know, a treatment landscape. And this was accepted by the Journal of Clinical Oncology, which is amazing because, you know, the journal is heavily involved presenting pharma studies. But maybe we should consider also a piece on lobular, that as academic community and pharma, it seems sometimes that the direction is differently. So this piece was very well received, and maybe, you know, see for lobular patients how we, you know, with pharma, with regulatory body, with guideline committees, you know, propose some solutions to make sure that the lobular patients get what they need. To zoom in a bit on the trial data, especially the Checkmate study team presented biomarkers. And I think this could also be applied to lobular, though they didn't participate in these trials. But as you know, in the beginning of my talk, it's not that lobular is totally different tumor microenvironment. So what this shows you, that if you have higher TILs, you see that the blue and the gray bar starts to deviate more. So though TILs in ER positive seem to be poor prognostic, for immunotherapy might be a good thing. So those ER positive, even with a few TILs, it did matter. More chance of reaching a PCR with immunotherapy. Also ER levels. I think the definition of ER positive, you know, it's really a mixed bag, because we all know that an ER of 30%, it's totally different than ER of 100%. Well, we still consider it one disease, also for lobular. But what this plot shows you, that if the ER levels are going down, their delta, resulting by adding the immunotherapy, is getting bigger, suggesting that ER highly positive, highly endocrine dependent are not the ones benefiting for the immunotherapy, but those that are a bit more heterogeneous, a bit lower in ER. So this could apply to lobular as well. So my outlook for early stage lobular is that I think we should create more awareness of that in those landmark trials, lobular patients can participate. Maybe not for the primary end, but at a certain cohort that we learn also for those patients. And then looking at the data coming from ductal, if I would do immunotherapy for lobular right now, I would say lobulars that are grade 3 have at least one TIL, because that was the cutoff, and have a bit lower ER. I think that will be the group that could benefit from immunotherapy in the early setting. Oh, most important slide. Yeah. I'm very grateful for a whole team. So, you know, it's my honor to present here. But the data that I present to you, it's coming from really academic trial, where not only at NKI, but also at certain Dutch hospitals, physicians that really believed, you know, that lobular deserve better treatment. They included patients, patients were referred. You see a picture of my team, so PhD students, bioinformaticians here at recent ESMO. Karen de Visser, my partner in crime, who works in the preclinical side, also on lobular. Pathologists were key here, and also the folks at NKI that, you know, study immune cells for the whole career, really provided feedback to making this initiative for immunotherapy for lobular patients possible. Thanks for your attention.
Thank you so much for that wonderful talk. I think we're going to save questions and discussion until the end, if that's okay.
Perfect, perfect.
It's my absolute pleasure to present Steffi Oosterrijk, who works from the Lee and Oosterrijk Laboratory at the University of Pittsburgh. How do you introduce Steffi otherwise? We're all here, have such immense gratitude for Steffi's work. She's been the catalyst that started the ILCSymposium, why we're all here today. She's one of the founders of Lobular Breast Cancer Alliance, and she drives the Glob Mob, which, for those who've not heard about it, is a network of clinicians, researchers, and patient advocates around the world. And on behalf of all the patient advocates here, she's absolutely driven our engagement within the research and clinical world of ILC. We affectionately know her as our Glob Mom, so I'm absolutely delighted to present Steffi.
Thank you very much for this embarrassing introduction, but I'm pleased. So on this last day of the symposium, I think I would already like to congratulate Christine and team. I think it's an absolutely fabulous meeting, and it's really... We do know how much effort that takes, so I think it's really fantastic, yeah. So I'm going to speak today about comparison of the immune infiltrate between ILC and NST, and I would like to start to say that I'm not an immunologist. This is something we got into a few years ago, and I think it's only possible, really. It's one of those examples where I think you absolutely have multidisciplinary teams working together. We were lucky that Ada and I worked together with Dario Vignali, who's a seasoned immunologist at the University of Pittsburgh, with Dr. Tseng, who's a biostatistician turned bioinformatician. And we have, as you know, great interaction with our clinicians, and specifically in this case with the breast surgeon, Priscilla McAuliffe, who's in the audience. And then the two studies I'm going to share were done by two students, and this is Saili Onka and Chelsea Chen. And, you know, on the last slide, I show many, many more collaborators. It's really a large collaborative team, including a number of people from the Department of Pathology and many more. So just in case you don't follow all of it, I will summarize the main messages. So overall, while the overall immune infiltration in ER-positive ILC is similar to the ER-positive NST, there are clearly differences. There's a lower immune infiltrate, and there's an increased M2 to M1 macrophage ratio in ILC. There are clearly differences in gene expression, especially in macrophages, but also B cells. I do think the spatial relationship of the immune cells is absolutely critical and will give us additional information in addition to just quantity. Multi-omics approaches, so more than one analysis of the clinical samples and the data is very important. It will provide additional information, and the differences which have been detected by a number of groups are currently not exploited clinically for treatment of patients with ILC. Clearly more work is required. It requires sophisticated, which unfortunately are very expensive technologies, multidisciplinary teams, and large cohorts, well-curated cohorts, as well as finally syngeneic in vivo models, so for us actually to be able to test this and understand mechanism of action. The slide has come up before. It's a teaching moment for the students. If you have a really good figure, people will show it over and over in their presentation. So this is one of the first studies to show from Christine's group that tilts are lower in ILC than in IDC, and this associated with more tilts are associated with worse outcome. This was also shown by Professor Salomon's group, very similar, again, that having more tilts is associated with worse outcome. And Marlene talked about this earlier, that curiously this is different to triple negative, ER negative breast cancer. So we set out a few years ago in this collaborative group to really comprehensively do analysis of the immune infiltrate in patients with ILC as well as in normal breast. And you can see this here. The normal came from reduction mammoplasties, and then we did analysis in fresh treatment-naive ER-positive IDC and ILC, as well as in fixed banked and FFP tissues. And we did immune phenotyping with flow cytometry, single cell, as well as multispectral IHC to really comprehensively characterize the immune system. The purpose of this slide is not for you to see the details, but only to say that we really, really did a very comprehensive analysis, and big picture, 10,000 feet bird's eye view, it's not that different between ER-positive IDC and ER-positive ILC. You really need to go deeper to then figure out the differences. So this is what we did, and I show you a few slides on this. So the first is Dario Vignali, the immunologist, really said you do absolutely need to look at first study of the expression of these inhibitory receptors. They came up earlier in the presentations. So basically, we looked at inhibitory receptor expression of PD-1, TIGIT, LAG3, TIM3, and CTLA4. None of the difference was significant, but you can see that there's higher expression of PD-1 on both CD4 and CD8 T cells, as well as there seems to be higher expression of TIGIT on CD8 T cells. So there's a hint, but clearly you need larger number. That might turn out right, or it might actually not validate. Yeah? What was pretty clear, and this is confirming some of the other prior studies, is that overall there's a lower immune infiltration in ER-positive ILC compared to ER-positive IDC. What the graph here represents is in gray benign breast tissue, in green tumor adjacent tissue, and in blue the tumor. And this is overall CD45 positive immune infiltration. And you can see in IDC and NST, the majority, this is 86%, harbored increased CD45 infiltrate over tumor adjacent tissue compared to 50% of the IDC. And this was brought up earlier by Marlene, basically, that this did not reach significance, but this is an association between the tumor infiltrate, the immune infiltrate, and the ER expression. So on the x-axis, ER expression. And you can see there's a trend that you have lower immune infiltrate with a higher ERH score. So this is not new, but I think it quantifies it, that the more ER you have, the more positive the tumors for ER, the lower the lower the immune infiltrators. What we did find then is that when you look at relative expression of all these different or presence of all these different immune cells, and we compared, can you please go back, man? Thank you. ER-positive IDC, ER-positive ILC, and triple negative. And in red are the macrophages that you can see in the tumor component, in the tumor bed, as well as in the stromal compartment. We have a higher presence of macrophages. And the macrophages, it's not only that you have more there, but also the composition. There's a change comparing IDC and ILC is basically the ratio of M2-like to M1-like macrophages is higher in ILC. And that's shown here on the right side of the slide. We were able to do something called neighborhood analysis, where you basically look at the spatial localization of these different immune cells relative to each other, as well as to the epithelial cells stained by pan-cytokeratin. And in an unbiased way, we identified 7 clusters. They're described here. So you have something, for example, tumor macrophage enriched, or, this is an easy example. Immune cell depleted tumors, so all the immune markers, CD20, CD8, CD4, FOXP3, CD68, they're all low. Pan-cytokeratin is high. Or another one, let's say, CD8 and macrophage enriched tumors where you have pan-cytokeratin high, CD8 high, CD68 high. So this came out in unbiased analysis. When we look at these neighborhoods, the CN2 neighborhood, the immune cell enriched, is low on ILC. That's what we would have predicted based on the prior quantification, similar to lymphocyte enriched stroma. Yeah? Now, what was interesting, if we then looked at these neighborhoods and outcome, and again, the numbers get smaller and smaller. So this is something where I think we need to be careful. I don't want to overinterpret, but it was interesting that the association with survival showed us, in this case, for lobular, that these immune cell-enriched tumor, lymphocyte-enriched stroma was actually associated with a decreased hazard ratio, right? So maybe suggesting it's not just the quantity. If you actually look at the localization of these immune cells, you might actually get additional, and I don't want to say more valuable, but interesting association with survival, which we haven't seen previously when we just counted. In the ductal tumors, we saw an association with survival with a CD8 CD8 and macrophage-enriched tumors, which we did not see in the lobula. So clearly differences between the neighborhoods and association with survival, which I thought was very interesting. We did single-cell sequencing of the CD45 positive cells, a total of 52,000 cells, identified 14 immune cell clusters, just using classical gene expression markers of these different immune cells, and then doing an analysis where you looked at transcriptional divergence. So we basically specifically set out which immune cells have the highest differences in gene expression between ER-positive IDC and ILC, CD45 cells. What we found was that the biggest difference in gene expression was in the macrophages, followed by the B cells. We did then look at specific gene expression, and this is in detail in the paper. There are just a couple of examples which were different between the ER-positive ILC and IDC. We also did cell-cell interaction analysis, and one of the interesting interaction which came out between the CD8 T cells and macrophages and ILC was specific integrins and TGF-beta, and again, this came up just in the prior talk. It's one of those things where I think the data is all deposited. We started to analyze it, but sometimes I feel that hopefully other groups also use the data and maybe even combine it with their data sets, because it's such a massive amount of data that it's just hard for one group to digest it. What's more and more coming up is that different groups also develop immune scores, immune signatures to predict prognosis, but also potentially in the future use it for response to immune therapy. This is a study published recently by Wang et al., where they deconvolute. In the end, they actually came up with two markers, CD68 and FOXP3, and showed that in their set of lobular breast cancer, this specifically was associated with worse outcome, which I was interesting. I want to share just a few slides at the end from a study with Chelsea Fang in our lab, did with, again, a large collaborative group. And this is actually in revision right now. This is where Chelsea very cleverly made basically use of a data set where we had both RNA sequencing data as well as multispectral immunohistochemistry data. So the first thing she did, just take the RNA-seq data, and she took the TCGA classifiers, and Dr. Cook really beautifully talked about this, that TCGA came up with these three transcriptomic groups, the proliferative, the immune, and the reactive. In this analysis, and I think it was seen on Marlene's slide as well, that the immune and the reactive clusters on the hierarchical clustering very similar together. Also, I think, obviously there are a limited number of samples, so we grouped those two together. We have the proliferative and the non-proliferative. Chelsea then took the analysis from the multispectral IHC. Doing this, she found two groups, just like, I guess, gut check, or this is labeled, this should be here, the stromal and the tumor B cells clustered together, the Tregs and the macrophages clustered together here, and then you have the stromal and the tumor CD4 and CD8 cells. She then, and I should say that the macrophages were the highest expressed in both in the stromal and the tumor region. Again, not totally surprising. Chelsea then looked at specific patterns of number of immune cells that cluster together. And she asked the question, which of those patterns is mostly differentiate these two transcriptomic signatures? And what came up was pattern 2, which was characterized again by the highest expression of macrophages. So the macrophage expression clearly differentiates the proliferative and the non-proliferative group. I'm sorry for those in the back, that's a little bit small, so I'll describe this. But she then made use of the RNA-seq data and asked the question, is there specific gene expression associations with gene expression and with presence of immune cells? The strongest associations were actually between gene expression and the lack the absence of macrophages. So negative association with both stromal as well as tumor macrophages. Chelsea developed a signature, she called it TAM low, for low presence of these macrophages, 483 genes. And GSV analysis showed that the majority of pathways were actually collagen, ECM degrading pathways. We haven't followed up on this, but it's like one of those things which I'm sure we'll discuss later on in the breakout session with a couple of really great groups here, Val and many other people working on this. What is actually the role of ECM in access of the immune infiltrate, in this case macrophages, to the tumor cells? And actually I should say that using that signature in MetaBreak to look at survival, we can see that when that signature is on, when it's high expression, that both disease-free survival as overall survival, it's basically associated with improved survival. So to summarize, overall, the immune infiltration in ER-positive ILC is similar to that in NST, so they are cold tumors. Marlene, I really love that painting. The difference includes there's a lower immune infiltrate, but there are more macrophages with increased M2 to M1 ratio. There are some changes in expression in these inhibitory receptors. The gene expression, there are gene expression differences in macrophages as well as in B cells. I really appreciate the prior speakers saying that, there are other immune cells, mast cells, B cells we haven't looked at all, which we don't understand their functional role in lobular breast tumors. I do think that the spatial relationships between these different immune cells is highly relevant. This came up earlier during the symposium, that there are efforts ongoing really on spatial sequencing. I think a couple of the groups in the audience work with Okin, a company in France. I think they have a collaboration with 6 institutions in Europe and in the US to do spatial sequencing as well as bulk sequencing in thousands of tumor samples, including breast tumors. And that, I think, will be very, very exciting. And there's an increasing development of immune biomarkers, right? And I just showed you the TAM low signatures associated with expression of ECM genes. I really look forward to the breakout session. I think the discussion of targeting immune cells other than T cells is very interesting. What's the role of the dense ECM? Got super excited about these of the ECM calves. The variants, the ILC variants, if you call them pleomorphic, if you call them grade 3 tumors, but clearly tumors which have higher TIL infiltration. And I have a couple of slides I didn't put here. I put them in for the breakout session. And Dr. Piano talked about the TILs in the pleomorphics, for example, yesterday. Very, very interesting. So, yeah, I'd like to conclude that there is limited understanding of these immune infiltrates, its functional and druggability in lobular breast cancer. I try to highlight the people who really did the work, and Chelsea and Siley, the trainees in the lab, Priscilla, the surgeon, George, bioinformatics, Dario, clearly the immunologist, and Peter Lucas was a main pathologist, but all the others. And yeah, Adrian and I really, like I said at the beginning, I think we really appreciate the multidisciplinary collaboration that kind of work needs, because we are also new. We jumped on the bandwagon. We are new to the immune cells, but we realized a few years ago you just absolutely cannot ignore this, and I look forward to further discussion. Even I think we are very interested in modeling. We are trying to combine now our PDOs with immune cells, but we have never put calves into these PDOs, for example. I mean, how can you not put calves in if they play this important role in even differentiating the immune cells? So anyway, thanks to the organizers, and thanks for listening to me.
Thanks very much, Steffi. So we've got time for questions. I'll just invite the speakers to join us at the front here. Thank you. Anne?
Thank you, Val. It was fabulous presentations. Thank you to the three speakers. I have a question for Marlene regarding the ER positivity of ILC and the response to immune therapy. We know that the 1% cutoff makes a tumor being ER positive. And don't you think that the response, you said it a little bit, but I would like you to comment on that. The response of ER positive tumors to immunotherapy, wouldn't it be for ER low expressor tumors? And the 10% cutoff we use in Europe is even, I think, not higher enough to recapitulate these ER low. And finally, the all-red score that combines percentage and intensity of expression might make sense. No? What do you think about that?
Yeah, thanks, Anne, for bringing up that topic. So, probably you know better, but why this cutoff of 1% or 10%? It's based on endocrine treatment, right? And the likelihood of responding to the treatment. There's even still ongoing discussion whether 1% or 10%, what is best for the endocrine treatment. But that seems to be set in stone. Now we talk about a totally different treatment. So maybe this needs a totally different cutoff. And so at ESMO, French group, because you used the 10%, presented data on the addition of pembrolizumab, so anti-PD-1, with chemotherapy. And the response rate was remarkably high. So if you have like ER 5%, in the United States you'll be considered ER positive, in France and the Netherlands triple negative, we treat as triple negative. They seem to benefit a lot from immunotherapy. So indeed I think this, supports the cutoff of 10%, or having a separate entity for ER low. Then if you talk more about immunotherapy, there are now several papers suggesting that if you go up to 50% of your ER, they are way more below the 50%, they're more likely to be basal-like, have more immune cells. And that I also presented, the biomarker data from the Checkmate 7FL, that indeed that the addition of immunotherapy for ER 50% is much bigger than if you have really classical luminal A. So but it's very difficult, I think, in medicine in general, maybe in the breast fields especially, to change this. And, I think we should all encourage each other to look at it and to spread the word and educate each other. Because maybe to find the right patient for immunotherapy, this cutoff might be totally different. Yeah.
Other questions behind you?
Okay, sorry. Okay, thanks a lot again for the three presentations. They were all brilliant, really fascinating. And actually, it's really nice to see that we are accumulating so much evidence now also on lobular tumors. So I have a question first for Marlene. So thanks a lot for the work you did on the Gelato trial. And I think it's really opening a lot of insights on metastatic ILC. But so now all patients with hormone receptor positive metastatic disease will be treated with CDK4/6 inhibitors. So what do you think the impact might be there on the tumor immune microenvironment, and what could be possibly the impact on getting later an immunotherapy there?
Yeah, a very relevant and timely question. So in Gelato study, the ER positive all had CDK4/6. If you look at in the papers, I think a couple of years ago there were 3 papers, big journals, got a lot of attention that CDK4/6 inhibitors could change the tumor microenvironment in a favorable manner. Later there were, of course, smaller papers, presenting data that's probably not true, or if you look at it from a different angle, it's not only going to that direction. So I think it's still an open question whether CDK4/6 inhibitors do something good to the tumor microenvironment. And also, it's maybe doing something good, but the disease progresses at the same time if you take a biopsy after. And, we know that if disease progresses, the tumor microenvironment unfavorably change, right? So then you might have a positive effect, but I think the disease progression overrules there. If you look at the clinical trials combining CDK4/6 with immunotherapy, Most of them stopped because of toxicity. So toxicity for CDK4/6 is usually okay, there's some diarrhea and some liver toxicity. But if you combine it with immunotherapy, you see the liver toxicity really becoming a problem, also the pneumonitis. So trials have stopped, which is, something that's, there's no return. But it seems that it really matters on what CDK4/6 inhibitor and what immunotherapy. For example, the avelumab, anti-PD-1, is a different antibody, targets probably more the macrophages than the T cells. And the PACE study coming from Dana-Farber combined avelumab, I think, with abemaciclib, and there was no special toxicity. So again, opening the door for this. So I think, having first data on, does something good to the tumor microenvironment, and then smaller papers being against it, and in the immunotherapy field, stopping trials, don't go there, and then having a trial that at least suggests it is safe, I think it complicated to really address your question. But I hope that more trials will combine it, especially for patients with metastatic disease, and maybe not for all, but taking the ER low, for example, or ER intermediate, to see whether those patients can really benefit from immunotherapy.
Okay, thanks a lot. Yeah, and I think we also still need to see whether there's a difference for labular versus NST in that context as well.
Yes, yeah, but that requires that we really, join forces to say, at least a certain number of lobular patients need to be treated in those trials, right? Yes. Otherwise, we will never get there.
Yes. Yeah. Can I ask a second question?
Can I just follow up on this? So what was the rationale for excluding the lobulars in the Keynote 756? Because they had they were high-risk patient in the lobulars.
Yeah, so I don't know about the Keynote 756 because I was not involved, but I am, kind of a junior member, I would say, on the steering committee of the BMS trial. So seeing this, I reached out to, the hotshots of the PIs and the more senior people in the steering committee. And I was like, yeah, it's difficult to judge because you're not sure whether it's really a PCR and maybe the resection, incomplete resections, blah, blah. Yeah. So it's, it really, if you put something on the table, there are very practical arguments why not to. And I think in the end, pharma decides and they're not enough aware. And then the PI of studies, they want to have a positive study with not that much of a discussion. But then you really exclude super high-risk patients. So I think it's all, we should keep asking. And maybe, there is, I think, a nice report on clinical trials in lobular, but especially for the early setting, with PCR endpoints, different issues. Yeah.
I think if I may comment for the other trial, I was discussing then with the PI, with Fatima Cardozo, and at the time, actually, when I asked her, she said, aren't they included? So she actually forgot that at the beginning they were excluded.
So awareness, even
so
among
I think it's really a problem. It's like these patients are often excluded by definitions. It's like patients with inflammatory breast cancer. It's others, you just systematically exclude them to make sure you have a cleaner,
Yeah, the inflammatories in the checkmate 7 were included.
Yes.
So that's specified in the protocol, which is good. But now, lobular should be in there.
There's a question at the back.
Yeah. Is it on? Yeah. Hi. I'm aware of a few reports over the past few years that there's in metastatic ILC, there may be a higher subset of patients with high TMB, tumor mutational burden. And I wondered if any of your data has looked at whether they have a different immune infiltrate and whether that marks a group that may respond more favorably to checkpoint inhibitors.
Yeah, I think that's a fabulous question. I don't know the answer to this. I think we worked with Foundation Medicine. We published a few years ago on comparing METs in ILC to IDC, that there are higher TMBs, but we have not been able to actually go back to the slides with Foundation Medicine to actually do TIL counting in those samples. There were some issues. So I don't know if anybody else has done it.
At least in the small gelato trial, we didn't see a link with TMB and immunotherapy outcome. I think, maybe I'm not polite to the TMB lovers, but I think TMB is a bit overrated when you look at biomarkers. So there is, if you look at it's approved in the United States, right, as a biomarker across tumor types, but it's really driven by, I think, lung cancer and certain gynecological cancers, while in the other cancers it didn't perform well. And if you look in breast cancer, though you see, if you have a trial where patients with a certain TMB level can enter and then they see a certain response rate, it's linked to the TMB level, but there's no control group. So I think, you know, at the current state, TMB in breast cancer, it's not a biomarker to select patients for immunotherapy. And for lobular, probably the same, but the question is still open. But happy to hear, probably you use TMB in your practice, right? Yeah. So can you
So like Marlene mentioned, in the United States, we do have a tumor agnostic approval for pembrolizumab in solid tumors that have high TMB. And so we do check for that specifically, either from tissue or even now a lot of the liquid biopsies can read out TMB, although there's some questions whether they're comparable in terms of the cutoffs that we use. Anecdotally, I've seen no responses in the patients that we treat in our practice with single agent pembrolizumab in the ER positive setting. And the blanket trial that you mentioned that included all solid tumors with high TMB, there were very few breast cancer patients in there, and again, not high response rates. So I agree, I don't think that this is a very relevant biomarker, especially in the ER positive setting.
There are certain breast cancer patients that are really hyper-mutated. So those are the MSI, mismatch repair deficient, and the patients having a POL-E mutation. Very rare. I think together it's less than 2%. Though I think if you have a high volume center, you have those women, you know, in front of you. So indeed I have ER positive metastatic high TMB or MSI that have a very durable response for immunotherapy. But indeed super rare.
I have a related question. In your trial, specifically, it was the triple negative patients that had a more durable response. When we look at, obviously we have a lot more data on triple negative breast cancer patients' response to immunotherapy, both early stage and metastatic settings. Did any of the trials report out histology in those studies? Do you know, in the big keynote trials for early stage or late stage metastatic or triple negative patients, was there any breakdown by histology? Do we know anything about those patients?
Yeah, good question. I think it has not been reported. I think the data should have been collected in the ECRF. But even so, at ESMO we presented like a multi-center immunotherapy trial in the Netherlands, close to 300 patients, and preparing the talk like, did we collect? So even if investigators, if you're so focused on TMB, of triple negative and immunotherapy, it's not an obvious thing to put in the CRF, which is, you know, for me it was kind of shocking, like, oh, did we collect? It's not in table 1, oh wow. Even with my awareness for lobular. Yeah.
Okay, I think...
I'm sorry, one second. The triple negative status, that was in the primary tumor, that was not in the metastatic setting, right? In your trial?
No, it's receptor status was done on the metastatic lesion. So that we use... Exactly, there were a few. Yeah, that I think it's a 5 to 10%. We call it receptor conversion. I'm not sure whether that's the right terminology, but at least a loss of receptors. Yeah.
So I think we probably have to move on, just in the interest of time. Are we? Is that?
Can I
are we okay?
Can I? Yeah. So, can I ask a question to Fatima?
All right. So yeah, we're till 10:30. Yeah. Yeah. Okay. Yeah. Adrian, have you got a question?
Marlene, I have a quick question for you. You have this priming with platinum chemotherapy, but most lobulars are known to be relatively resistant to chemotherapy, particularly the ER-positive ones. There is some suggestion that they might be more sensitive to radiotherapy, and I wonder whether you or others have considered priming with radiotherapy in that setting.
Yeah, wonderful question. I didn't have time to put it in my presentation, but last week at ESMO there was a beautiful trial presented, the NEO-CheckRay, coming here from Belgium. I think Bordet Institute was the main sponsor. It was luminal B, a neoadjuvant where classically we give like chemotherapy, surgery, and then the radiation comes after, sometimes with a boost for high risk. And what I did in the trial, they put a boost of the radiation at the beginning of the chemoimmunotherapy. And what they presented, that especially for the cold tumor, so luminal B, PD-L1 negative, it was a huge increase in PCR. And I reached out to the investigators. Oh, are there lobulars? And yes, there were 3 or 4, and they're, as we speak, checking their responses. Numbers are too small to say something on lobular, but I think that trial suggests that indeed priming with, a boost or a tape of radiation might be a good thing for cold tumors.
Yeah, Matthew Sikora has this data that suggests that the lobulars seem to have this DNA repair deficit that makes them sensitive to radiotherapy. So maybe that would be a nice...
Yeah, looking forward to the answer on the lobular cancers in that trial type,
I'm Patrick Neven from Leuven. I liked these 3 presentations. Thank you so much. Lobular breast cancers are mainly seen in postmenopausal patients because that's where we see most breast cancers, but also in women on hormone replacement treatment, taking estrogens, progestogens. I do remember that these sex steroids affect macrophages, like in endometriosis, also in breast cancer. What is the effect of these estrogens on the macrophage? Did you study that, or is that a potential interaction?
Yeah, I can comment on this. So there have been a few studies out, most recently from Donald McDonald at Duke, to really show that sex steroids and sex steroid receptor are expressed in macrophages and have an effect on macrophages. I think it is still, now getting the data on the single cell sequencing, I think we'll know a lot more in the near future. Adrian, I don't know if you want to speak a little bit about Neil's study. So we have done studies where we have taken monocytes into cultures and just treated them with E1 and E2, and we clearly see an effect on polarization of macrophages in culture. So I think there isn't that much data out, but I think there's more and more data out that estrogens can have direct effects on macrophage polarizations.
Because for lobular, they are an important risk factor in menopausal patients.
Yes, no, I totally agree.
And if you study the core needle biopsy, it might be taken while the patient is on estrogens. And if you study the resection specimen, the patient might be 2 or 3 weeks off. And we know that stopping estrogens or progesterones, they make a lot of difference for breast cancer expression markers.
Yeah, no, I totally agree.
My question is, I'm wondering if anybody is looking at neutrophils, platelets, or cancer stem cells and immune response in lobular.
Tough question. I think platelets, I'm not aware of good data on how they affect the immune response, at least not on the clinical side. For neutrophils, there's plenty of data. Though it's hampered because neutrophils are very fragile. If you freeze them and then thaw them, you lose them. So for single cell protocols, it really depends on how you process your sample. I think if you freeze and then you only find a few, and maybe within the neutrophils you lose a specific subtype as well. But in general, neutrophils are not a good thing for your T-cell response. Though what you see in biopsies of patients responding to immunotherapy, you see a lot of neutrophils coming in. And that's kind of counterintuitive. But probably that's a consequence of an immune response where the immune cells are cleaning up the tumor, the neutrophils start to help. So maybe it has nothing to do with the actual immune response, but more like a cleaning up response. I think it's more that the neutrophils, the data are pointing towards a poor prognosis, and not on something really, blocking the immune response. There have been attempts to target neutrophils with anti-GCSF, but I think those trials were negative or that was too toxic. It's difficult. If you deplete your neutrophils, you cannot live because you will die of like a massive infection. And that's why it's hampering the immune response. But Fatima, you can comment?
No, that's exactly what you said. Indeed, the neutrophils data, we have very high degree of difficulties to analyze them because indeed they are fragile. The quality of the data are quite low, and then just to have a high percentage of data analyzed and really carefully annotated, it's really difficult. Then your question is really totally valid, and we need to investigate also the role of neutrophils. But I just wanted to add that indeed, we are interrogating the impact of immunotherapies even without considering the CAF heterogeneity for the moment. Nobody cares about the CAF heterogeneity when a patient is also treated with immunotherapies, while indeed we know that this population could be abundant, and I decipher different mechanisms, either in IDC, in non-classic ILC, and in classic ILC, where we do observe an impact on immunotherapy resistance. Then that's why, for me, this is really an underestimated component of immunotherapy efficiency, because it's clearly one missing partner, which can be really important for regulating Tregs, for regulating CD8 T cells, cytotoxicity of CD8 T cells. Then, and I think this is really something that we now need to take into account, the accumulation of these ECM MyCAF, FAP positive CAF, wound MyCAF, TGF beta MyCAF. But this is we need to do it. We need really to do it. And if I can just also mention, we haven't done that in lobular carcinoma, but for instance, in ovarian carcinoma, what we found, we compare the impact of a chemotherapy on this CAF population, which patients with ovarian cancer accumulate a lot of FAP positive CAF, more or less as in lobular carcinoma. And what we found is that in some patients, the chemotherapy really deactivates the CAF, which is a very good point, because indeed, you deactivate the CAF and indeed you may improve the immunotherapy effect. But in a quite high number of patients, the chemotherapy either does not function on the CAF and the level of activated CAF remains very high or even increase after chemotherapy. And this means that here in these patients, we have to understand why this patient, the maintenance of this FAP positive CAF remains in these patients. And a lot of things need to be done both in terms of knowledge, but also in terms of therapies. And here the patient advocates can be very important in that matter.
Just to follow up from that, Fatima, is there any efforts, or I guess you're thinking about if you could reprogram the different CAF populations and whether that's going to be possible to do that clinically? Is that?
Yeah, thank you, Val. It's an important point indeed. That's exactly what we are trying to do here at Institut Curie with a specific program of research called Cassiopeia. Then what we try to do is we have identified the markers on this ECM MyCAF, wound MyCAF, TGF beta MyCAF, which is anthrax, the anthrax receptor, which is highly expressed specifically in these specific populations of CAF. And we try to really target it. We are trying to really develop agents to target this receptor and to check whether this indeed can really decrease, at least to kill these cells, perhaps not to reprogram them, because I have shown that in our recent paper we found the fact that the ICAF can become MyCAF through two different pathways, one which involved YAP
signaling pathway, and another one which involves DPP4, which is an insulin mediator. And what we found is that if we inactivate only one, the other way is really valid. Then you have to inactivate the two. Then I guess that in clinics this will not be possible. Then really to kill these cells might be the one opportunity, or to block them.
I had a question this is Guilherme from Dana-Farber. I had a question to Fatima too. There has been a growing interest in radioligand therapies in different cancer types recently, and including the use of FAPI as a target. Wanted to know your thoughts about the possibility of using radioligand therapy targeting FAP for the treatment of lobular breast cancer.
Yes, thank you for this question. In France, at Institut Curie, with Professor François Clément Bidard and Professor Anne-Vincent Salomon, we are the first to study FAPI in a clinical trial called Skyline in triple-negative breast cancer patients. Then, indeed, we are now involved in that study, and we are comparing FAPI signaling with single-cell analysis, EHC, and spatial transcriptomic data. And we know now that indeed, when we have high FAPI signal, we are more with MyCAF, but we have also some FAPI low signaling, which is associated with inflammatory CAF, which are very bad guys as well, for instance, in lobular carcinoma. Then indeed, we are exactly doing that now, because we need to have a right signal with a right identification of a CAF population just to be able to target the specific ones, which are the bad guys in patients. Yes, thank you.
Yeah, sorry, I have actually many other questions, but I'll focus on yeah, sorry, it's very nice session and very stimulating. So first a question actually which goes to the different speakers. For example, in the brilliant data that you showed, Fatima, on why we get the different CAF population because of icadherin loss, and that's actually the driver mechanism. Do you expect similar differences then between triple-negative ILC and triple-negative NST? Or did you look at that already? Did you explore that? And then it goes to my question then to Marleen, because I think, immune checkpoint inhibitors are approved, in triple-negative in the early setting, but to my knowledge, we do not have data yet on whether there is an efficacy differentially in patients with lobular cancer, how it impacts, how it changes, systemically and in the tumor. So I don't know if both of you could comment on that.
Yeah, perhaps this is a very good idea that Anne really wanted to do that, and we are currently doing that because this is an important question, but I do not have the answer yet. But this is a very important point, yes.
Yeah, and we're going to assess that in clinical, the triple-negative breast cancer treated according to the Keynote 522 protocol, and so we will have the answer. Yeah.
Yeah, I think for the primary trial data, it's not being presented. I think there's also this piece where we call it like academic uphill battle, because trials where over thousands of patients have been included. It's an enormous resource. And patients provide consent. They send their biopsies is going to industry. And then we don't see the data. And even on histology, it's not a good thing, right? We need to know. And maybe it's not changing practice, but at least that you have a hint on whether it's good or not to use immunotherapy. Let's say if there's like enormous toxicity and you've seen data in trials that they don't benefit, then you would stop way earlier than if that is the group where you have a clear benefit. Yeah.
Just very quickly, I think there's quite a growing evidence for the role of the androgen receptor in T-cell activity. And few people showed that androgen receptor is highly expressed in these triple-negative ILCs. So I don't know if that's the same when you lose ER, when you have a luminal A or luminal B ILC, and then you lose ER in the metastatic setting. So in the metastasis, do you also have high androgen receptor expression?
I think, yes, we have In the gelato trial, we measured at least, we looked at the gene expression. Maybe that's not the best proxy for androgen receptor, but it was still there. And it seems from, that's more in the early setting for triple negative, that those that have that are luminal A, luminal AR, or have an androgen receptor are less likely to benefit from immunotherapy. But that's coming from a small trial with only immunotherapy. So I think we need more data on that as well.
Yeah. Anne, did you have a final question?
Well, it's a question and a remark. To translate into clinical practice, all these information, this will be challenging, of course. So that's why we need either immunohistochemistry markers, robust, reproducible, interpretable easily if we want to that these informations benefit to the large number of patients with breast cancer and lobular breast cancer. So markers of anthrax, FAP, and Syndecan, they are accessible in the clinical trial you mentioned, Fatima, Skyline. We are investigating it, but the time between research, clinical research, and clinical practice, you know all that it's a long journey. And maybe, I don't know if it's thinkable, but to introduce single-cell analysis into clinical practice with biopsies, I envision that like a perspective, but it's always time-consuming, difficult, etc., etc. So, yeah.
I just wanted to follow up on that point, because I think one thing which is important, researcher like me, we really like to have an impact on the patient understanding and treatment. And what we can do now is really to develop, to use AI, and this is not just to be in the mood. This is really something that we think. For instance, Anne has developed an AI software for defining BRCNS, and that now what we are doing currently in the lab is really to combine spatial transcriptomic data deconvolute at single cell level into AI software where we could perhaps, we hope, we don't know it, this will be in future, we could develop AI software by which on HE section you can identify this specific calf population without doing all this stuff that we are currently doing. Then this could be adapted in clinics. And this is really something that research can really provide to the clinical benefit. At least we hope. And it's what we are trying to do now.
Okay, one last question.
Yeah.
What can patient advocates do to help academic centers and encourage pharmaceutical companies to include lobular patients, to run lobular clinical trials? Is there a role for us to hold their feet to the fire, perhaps? Little public shaming campaigns on Twitter? I mean, what can we do to fast forward the research and get them to listen and get the word out?
Yeah, thank you very much for the question. I think patient advocates are super influential. And I think, you know, maybe not shaming them on Twitter whatsoever, but I think creating awareness and keep asking the questions. I was thinking of like ESMO, every trial I presented, I will stand up and ask a question on lobular. Probably the chairs won't like it, but I think those things, awareness in a very friendly manner, it will for sure help. And I think for, you know, more academic community, you know, have a serious discussion on where our influence is in this is also, I think, very timely now. You want to comment?
Yeah, no, I totally agree. I do think, and we chatted about this last night, actually there's no doubt that when you talk to pharma, when you talk to researchers, when you talk to clinicians, that there's a general idea, oh, there's a very strong advocacy community in the lobular breast cancer world. There's no question about this. More so than I think in other subtypes of breast cancer. And I think continue what you have been doing. I think there's so much more awareness now, and even, you know, the beautiful pieces you write, I think it's not only researchers reading this. So yeah, I think it has been tremendous progress.
If I may just comment on that. Yeah, I got the mic, sorry. No, so I think
there is really some progress there. I think that there are really some pharma companies who slowly are opening the window to allow, sub-analysis for patients with lobular, or even considering in a second phase to consider, central pathology review of the cases. And I think that's really good. And I think we should use those, companies for some trials who are willing to do this effort to show to other companies. And this is working. If you show, look, we're starting, why aren't you following? And I think these are things that we should use and that we can do.
Yeah, no, I just wanted to add, I totally agree with what has been said. And as Marlene said, PI or companies are really afraid by negative results. But better understanding of a pathology and ILC will help in and to be beneficial to the patients than to have positive impact of clinical trials. And here patient advocates are really key in that issue, that indeed what has been shown by Steffi on macrophages, all the data that we obtain in clinical trials, all things that we have on CAF will provide better understanding and less fear. People should not be frightened of including you in, because we will better understand why some patients will not respond and why patients could also respond. And that, I think, with education, it's what Christina said, education of both companies and PIs as well will help in that matter, and you will be critical in that point.
I think one of the things as a patient advocate that we can do isn't the Twitter shaming, but all of those that are on Twitter, all of those that are on LinkedIn, and I try to do it every time I see, is whenever a piece of research is published, if we all asked, oh, do you mind sharing the lobular data you've got from that piece of research if it's not there? And it's presented in a really respectful, really positive, and providing the information way. And if we do that en masse and commit to doing that together, then that kind of drives the message home as well, that we're looking for that histological data from trials and research results.
Yeah, and just very quickly, I think it is, I'm not a clinician, but I work with a lot of clinicians like Julia at our institutions, and it is tough to do clinical trials in a patient population of 10 to 15%, and now even thinking of if you even want to do a clinical trial within a subpopulation of patients with ALSI, it is challenging just based on the numbers, right? So I think talk to patients to just convince them clinical trials is a great thing. It's clinical trial. I mean, we have problems like most other cancer centers that accrual to clinical trials is lower than it should be. And it's even worse in minority populations, right? There is still the fear based on history that clinical trials is not a good idea. So I think to just talk to other patients that to make progress in ALSI, we need to have clinical trials.
I'm a patient advocate since 2012 in the Netherlands for the Breast Cancer Association. And I was clapping on the doors in the Netherlands. I sent emails to the NKI several years, but never comes lobular on the agenda. And I'm very glad and very proud on the ILCSymposium, and I want to give them a compliment because they are an entity, and that's we need also, we give awareness, and we have back with us the ILCSymposium, so we are, they listen better to us. And that's what we want to do as patient advocates from the ILCSymposium to give more awareness on this. And also in the Netherlands, that's my home province, and we are going further with this to get more the lobular on the agenda, and that patients are included and not excluded. It's a pity.
Okay, thank you all for that very nice discussion. And thank you once again to all the speakers this morning. That was a great session, and I encourage you to join the breakout session on the tumour microenvironment after the break for further discussions.